to this discussion in vascular surgery and look at the clinical scenario. So have a careful look. So it's a emergency presentation. Elderly gentleman who has collapsed at home and brought to the A&E by the relations. So in this type of very ill patient, it is very important that even prior to making the diagnosis, to do the airway breathing circulation, take a coma scale, because the these vital functions may have to be resuscitated. Otherwise, sometimes these critically ill patients may have a cardiac arrest. So initial thing is to do the primary survey, but it's very important to have in our back of mind what are the possibilities in this type of patient, because some of these possibilities we may even find during the primary survey. Even if not very soon, we have to come into a quick working diagnosis to treat the patient immediately. So before going into what we saw in the assessment, just to recall what are the pathologies where a person can collapse and present. It could be a sudden airway obstruction due to maybe a foreign body, or a problem of breathing. It may be some form of respiratory failure, maybe an acute exacerbation of asthma, or maybe some failure of oxygenation like a severe pneumonia, or a cardiac failure with pulmonary congestion, or it may even be a sudden tension pneumothorax, or it could be a cardiovascular, a person coming in shock will collapse the patient, or it could be a neurological, where there is maybe a head injury or some cerebrovascular accident, either a hemorrhage or infarct, or a metabolic cause also, which actually causes collapse because mainly the effects on the cerebrum, like hyperglycemia or hypoglycemia especially. So very important to do a immediate uh, testing for blood sugar in this type of patients. Or it may be due to some form of other metabolic thing like a hepatic encephalopathy or renal failure. Or also it could be maybe an endocrine problem like Addison's crisis. So all this should be in back of mind. But anyway, as this patient brought in, his airway was okay. When we spoke, he was responding to our verbal commands, even though he was restless. Breathing, he was tachypnic. So we immediately started him on oxygen, and also the saturations showed low levels. So we did a quick respiratory system examination, and it was normal except this high respiratory rate. So there was no reason for a respiratory pathology for his collapse. So he did not have any evidence of like a tension pneumothorax. He had good air entry. There were no basal crepes, and then the circulation. So he was in shock. So now this is probably the probable reason. Still, we have not done the disable, but I said he was actually responded verbal commands. So it's unlike to be a neurological cause. But anyway, shock. So what are the possibilities in? Can it be a cardiogenic shock? Bit unlikely because it's not orthopnic. Neck veins are not distended, and he didn't have any basal crepes, and the ECG doesn't show any direct evidence of a ischemia. And could it be a obstructive shock? Unlikely, because you have excluded tension pneumothorax. Cannot be a tamponade, cannot be a severe pulmonary embolism. He doesn't have any distended neck veins. And then a distributed shock, septic shock. Of course, the relation said he was well in the morning, except he was complaining of a bit of some discomfort in the abdomen. He didn't have any fever, so septic shock unlikely, and he was not exposed to any allergens to cause a hypersensitivity reaction. And Neurogenic shock. The common cause for neurogenic shock is of course spinal cord transection with severe vasodilatation. He didn't have any trauma. So it is very likely that he has a hypovolemic shock. So dehydration, but he didn't have any vomiting or diarrhea. So it's very likely that he has an internal hemorrhage and there was no trauma here. So the likely possibility is that he has intraperitoneal bleeding. But anyway, with this shock situation and likely to be a hypovolemic shock, he was started on fast fluid resuscitation, and also bloods were sent for investigations, cross-matching, also arterial blood gas analysis. And a quick response or disability, of course, responding well to verbal stimuli. So, of course, then he needs a full examination, a quick head chest examination done again, abdomen. Well, he was like fading away, very restless. But of course, there was a distended abdomen and some tenderness, so it was very likely that there is an intra-abdominal hemorrhage. Two possibilities. It could be intraperitoneal bleeding, like from aortic aneurysm ruptured, or maybe really a liver tumor bleeding, or maybe he had a splenomegaly with minor trauma, he's bleeding. And the other possibility is where there's a concealed GI hemorrhage. Some people have severe GI bleeds without showing any hematemesis or melena. It's not very common, but we have to consider. So, what is the first thing to do? Do a fast scan. In the ICU itself, he was actually pushed soon to the ICU. And in the ICU for all his supportive treatment, it's very easy. And in the ICU, we did a fast scan which showed evidence of intraperitoneal bleeding. And also it showed evidence of a aortic aneurysm. And since we do vascular surgery at Peradeniya Hospital, we took him to the theatre because you can't get the blood pressures up to beyond a certain level because there's continual bleeding. So we took to the theatre for emergency laparotomy and cleaned and draped everything ready, induced and a quick entry into the abdomen. There was a bleeding aortic aneurysm and the neck was clamped. And then of course the bleeding settles and you open the aneurysm sac and place a graft, do a repair with a graft. And then the aneurysm sac, of course, you can suture. You don't have to remove the aneurysm sac. You just open it up to the neck of the clamp, and then there you anastomose the top end and the two limbs. His aneurysm was going into the iliacs also, so we did the anastomosis into the two femoral arteries, and then he was sent to the ICU for further management. So looking at the presentation of aortic aneurysm, so this is an emergency presentation that we discuss, who comes with a ruptured aortic aneurysm, but he presents as a collapse, and then a quick evaluation to support the systems and also a quick diagnosis is possible if you are aware of the conditions. And it was confirmed with a ultrasound and then emergency surgeries save the patient. But in a general way, what are the ways aortic aneurysm can present? Some people are asymptomatic. Some people are asymptomatic, but they may be diagnosed as an incidental finding. You do an ultrasound scan for something else and you find this aneurysm. That is one way. Or the symptomatic. They can come with some symptoms and it may be elective in the sense it's not an emergency. They come to the clinic with some complaint, but we'll evaluate what could be this and also of course with emergency presentations. First we'll take the asymptomatic. You do a scan for something else and you find an aneurysm. What are you going to do? Of course, you may do a CT to get further information about the correct dimensions, but a good ultrasound will give all this information. And all what you do, the primary determinant is the size. The primary determinant is the size. The secondary determinant, of course, the patient's general health, but the primary determinant, if it's between 3.5 to 4.5, you observe the patient with an annual ultrasound scan. If it's not enlarging, you can keep on observing. between 4.5 to 5.5 centimeters. You do a ultrasound every 6 months. Every 6 months, and if it remain below 5.5, you observe. Does that mean that these aneurysms will not rupture? No, it can. But of course, the risk of death from rupture, you compare with the risk of mortality from surgery, because these surgeries are high risk. You go and clamp the aorta, major laparotomy, so there is a definite uh, recorded mortality from these surgeries. So you compare. So when you compare, the risk of dying from rupture is much less than the mortality risk of surgery at these levels. So you don't operate, but in the lower level, you do annual scan. That's perfectly enough. And this range you do once in 6 months. And the diameter we are talking here is the AP diameter. It's the length is immaterial. You have to look at the AP diameter, which gives the prediction, the chance for rupture is that. And it is above 5.5 centimeters. Say you have a asymptomatic patient, but the AP diameter is over 5.5 centimeter. Then you have to consider elective repair of the aneurysm. Then the secondary development come the condition of the patient. So if you have a very elderly patient, say 90 years, with multiple comorbidities, of course you may decide to observe, because there the mortality can be high. So if it's over 5.5, if the patient has a good risk for surgery, you plan for your elective aneurysm repair. So that is how you manage asymptomatic people. Then get into the symptomatic. First we'll take the elective presentations, where they come to the clinic with some symptoms. So what are the common symptoms? So there is something enlarging in your abdomen. So they commonly come with some feeling of abdominal fullness. It may look like some dyspeptic symptom. And the dyspeptic symptoms, this upper abdominal vague presentations, we have discussed in one of our earlier GI discussions, and the differential diagnosis there we mentioned chronic pathologies in the upper abdominal viscera like peptic ulcer disease, chronic pancreatitis, chronic cholecystitis, and also maybe early malignancy. So you take a good history and physical science, and when you examine, of course, you may feel the aneurysm. And some people actually they come and say that they have some mass, which we sometimes they say they can feel pulsating. So it's not difficult to diagnose, but of course you have to take a good differential diagnosis, because you have to be sure that this abdominal pain is due to the aneurysm. Say some people may come with some dyspepsia due to peptic ulcer, and also they may have aneurysm. So you have to be exactly sure the symptoms are not due to some other pathology, but it is due to aneurysm, because you're going to take a very big decision if you decide to operate on this patient. And another common presentation is of course backache, because they press on the vertebra and there may be some vertebral erosion, so they can have a chronic backache. But it's very important to know these usually these aneurysms present in middle or late ages, and backaches are very common in those people. So again, you have to exclude another cause for backache and be sure that the symptoms are due to the aneurysm. But there's another important thing. Now anyway, your examination, you find the aneurysm and you do a imaging, you do ultrasound and maybe even a CT. And most of the people when they start symptoms, usually their aneurysm is larger than 5.5 centimeters. So it is not difficult to make the decision, because even if they were asymptomatic, you may operate. So these symptomatic aneurysms coming in with early symptoms of abdominal pain, backache, but of course you have to exclude other diseases. Very important to do that. Because you can't, with a gastric cancer who comes with the dyspeptic symptoms, you feel aneurysm, so it's not good. So you have to take a good history, examine, and you may have to do some other investigations also to exclude other disease if there's a fair amount of doubt of another disease. But you do a imaging, and you generally, as I said earlier, people who come with this abdominal pains, backache, if it is due to the aneurysm, generally the aneurysm size also will be in a range where you may anyway decide to operate. So again, in these cases, so if you think the aneurysm is due to is causing trouble for the patient, and then again you arrange for a elective repair for these patients. And then we come to the emergency presentations, and one we discuss the rupture. And the case that we presented, it had ruptured into the peritoneal cavity, the commonest region into which it will rupture. Some cases it may rupture the duodenum, because duodenum is in very close relationship with the aorta. So it can rupture into the duodenum, where they present with a severe hematemesis or maybe a severe melena, or sometimes it can come as acute bleeding per rectum. So if those persons with continue to have hematemesis, they collapse, they difficult to resuscitate, or a severe melena, severe bleeding PR, always you have to consider aortoduodenal fistulation. And some cases they may rupture into the inferior vena cava. That they get a aortocaval fistula, a sudden preload into the heart, and they go into congestive cardiac failure. So they who go into a sudden onset cardiac failure with some abdominal symptoms, I think it's worth considering aortoiliac fistula as well. These are not common, but it's always better to keep in mind, because you may be able to salvage a patient. But the importance is all these ruptures generally their outcome is not very good. But if they are rapidly brought to the hospital, a rapid diagnosis is made, these general conditions are otherwise okay, and you may be able to salvage a patient if your actions are quick. Then there's another subset which we call leaking aneurysm. This is, the aorta is a retroperitoneal organ, and the initial bleeds may be held up by the peritoneum with a clot tamponade, and they are still not actively bleeding into the free space. So leak, also they will have severe abdominal pain due to the stretching of the peritoneum. They will have a tachycardia, they may have some degree of hypotension, but they won't be in a severe shock like in a rupture. But anyway, so leak. Again, you make the diagnosis with ultrasound scan. If you can get an urgent CT, fine, and you operate, and they have a much better prognosis than a rupture. But of course, if you remember, person coming with a leak, you have to do quickly things, and before it rupture in your own ward, it is better to take to the theatre and operate, because if you operate before rupture, the person will have a good prognosis. The other emergency presentation is, of course, embolism, because all these aortic aneurysms, they have a clot within the distended sac. Usually, this sac, there will be all the cases. Definitely, there will be a thrombus. So sometimes small parts can go and embolize. So these cases present as a embolism. So they come with acute severe leg pain, and it's very important to know what are when the person comes acute severe leg pain, you have to know what are the other causes which can cause acute severe leg pain, and then you can work out, and ultimately you will diagnose. You, in some cases, if it is the cause, you will diagnose that it is a aortic aneurysm which has caused the embolus. So this acute ischemia, you read to the notes I have given on vascular or ward classes. It will have some discussion on this acute limb ischemia. But of course, say a person comes with acute limb ischemia, you diagnose its embolism, and you find out that it's a aortic aneurysm which are causing the emboli. The first thing that you do a embolectomy and first salvage the leg, get the leg revascularized. But very soon you have to do the repair the aneurysm, otherwise you can get repeated emboli going down. So just to summarize, aortic aneurysms, they can present in many ways. It may be that they are asymptomatic, and if it's asymptomatic aneurysm on incidental finding, your management is based on the size, and where here you manage conservatively with serial scanning, either once in 1 year or once in 6 months, to assess the AP diameter. But if it's over 5.5 centimeters, elective repair if the patient is fit. And then the elective presentation, abdominal pain and backache, if you know that it is due to the aneurysm, elective repair. And then the emergency presentations, rupture into one of these areas, or a leak, which is the presentation the patient is little better than a rupture, or embolism. And we have discussed how to manage, and we have illustrated a patient who has come with a ruptured aortic aneurysm, and when a person comes with a collapse situation, what is the approach and how you make the diagnosis. And just a small discussion on endovascular repair of aortic aneurysms. And it's an elegant technique because it's done through just a femoral puncture. You get a guide wire in, and over the guide wire, you pass a stent into the aorta, and you can even get another lymphated. If it's just the aorta only, you can place the stent graft in the aortic part. But if it extends into the iliac, of course, you have to get another limb pushed in through another guide wire and to hitch there. So you are going from inside the vessel and placing the aneurysm inside. But as opposed to the open repair we did, we have to do a big laparotomy. Maybe sometimes from syphis sternum to the pubis, a large incision may be necessary, and then you clamp the aorta, open the sac, and suture the graft there. But here, it's such a beautiful technique that you just from the vision over a guide wire you pass it. So what are the advantages in endovascular? There's no laparotomy. They don't need general anesthesia. You do with some sedation and local anesthetic. And also there's a one very important advantage. There's no aortic cross clamping, because these people are old elderly people with cross clamping. They can go into sudden cardiac failure. And also after you repair in an open surgery, then you declamp. With the declamp, again they can have problems. So there are a lot of advantages by doing a endovascular repair. And these, of course, the radiologists, they inject contrast during the procedure to see where the guide wires are in, when whether the graft is deployed at the correct position, and you see the graft, and now it is actually covered by the thing. So it's an advance in the minimal access techniques available, and this is one of the endovascular techniques for aortic aneurysms. And this also these graft placements are in aortic pathologies. They are done also uh, for aortic dissections. It's an elegant thing again, which you do on a guide wire, and you can save a life.